Welcome to the 23rd session of Progenesis Academy webinar series. Today topic is boost your fertility with natural remedies. When do medical interventions become necessary? We are very excited to have with us Dr. Kumar, Medical Director at Western Fertility, Dr. Bustillo, a fertility specialist at IVF MD in Florida. And we have with us Mr. Berkley. He is a founder, acupuncturist, and founder of the Berkley Center for Reproductive Wellness. Thank you so much for joining us.
Thank you.
We have some patients online with some questions, but I think I'm gonna start. My first question to you, Mr. Berkley, is what is your approach to those patients who are seeking fertility treatments? Give us a run through what you normally do with those kind of patients.
Sure, I'd be happy to, and please call me Mike. I'm definitely too young to be called Mister. I get patients all the time who are infertility cases. That's all that I treat. That's all that I've treated for 23 years. And I get every single type of patient, the same patients that you get. And I will never treat a patient unless she and her husband have an evaluation and are under the care of a reproductive endocrinologist. And I think this is extremely important. I'm not sure that all acupuncturists follow suit. My justification for insisting on this is I cannot tell the patency or lack thereof of the fallopian tubes. I don't know about polyps or fibroids. I don't know about sperm. I don't know about thickness of the lining. I know nothing. However, when you're treating the patient, you are privy to all that information, and then that can be shared with me. And what I like to do is to take all the Western medical information and kind of combine it with TCM, traditional Chinese medicine knowledge, and that helps me to arrive at a differential diagnosis according to TCM and treat accordingly. And I don't treat what I can't treat. So for example, if a woman has a rather large intercavitary fibroid, I'm not going to tell that patient I can shrink your fibroid. I'm going to suggest that she goes back to her doctor and tells the doctor and gets a myomectomy. I do a lot of, I request a lot of testing. Every patient that I have, I recommend that they do a fluid ultrasound to rule out polyps. I want to know what their blood work is. I don't really care anymore. I used to care a great deal about their day 3 numbers. I never look at day 3 numbers anymore. I find them to be highly irrelevant. And the reason that I find them to be irrelevant is because I've had 44-year-old patients with perfect day 3 numbers, but obviously the numbers are lying. So in my estimation, if a patient has a 28-day cycle or a 35-day cycle or a 40-day cycle, but it's regular, and she's ovulating regularly, that's all I care about. And so I'm very pro this concept of East meets West in reproductive medicine. I think I can do some things that you guys can't. And I think that you guys can do plenty of things that I can't. For example, we were talking before we went live about sperm DNA fragmentation. There's no real Western mechanism of intervention to improve sperm DNA fragmentation, but in Chinese medicine with acupuncture and herbs, I've lowered it significantly from 37, 38, 40 down into the 20s, the 18s, the 15s. Even trying to improve egg quality is not something that you guys necessarily do. We had this PRP, protein rich plasma. Some people believe in it, most people don't. But I think that I'm able sometimes, if I'm lucky, to improve egg quality. So my job is to try to improve egg quality, increase perfusion in the endometrium if it's a thin lining due to multiple utilization of Clomid, perhaps increase, improve sperm issues, whether it's morphology, motility, count, as long as it's not a physical anomaly. That's kind of how I interface with patients. If somebody has a severe varicocele and they get tested status post-varicocelectomy and they still have a very low sperm count, I will not treat that patient because I can't take dead tissue and make it come back to life. I think you're muted.
Sorry about that. Thank you so much. Dr. Bustillo and Dr. Kumar, tell us what's your approach towards infertility? Do you take into consideration reproductive wellness? Do you consider it as a piece of your treatment?
I didn't quite get the question. Say it again.
So when it comes to your approach to fertility treatment, where does reproductive wellness fit?
Oh, reproductive wellness is very important. And one of my pet peeves is obesity. All right. So a patient who is way overweight, you know, particularly BMIs greater than 35 is a problem, because we're learning more and more about inflammation associated with obesity. And so in our practice, we want to do IVF once and we want it to work. So we want to present to the table the best in both the man and the woman. So we have obese couples, and I really insist. We have a full-time nutritionist in our practice, and she helps us, and we do very well. And sometimes when we make the patient well, they don't need us anymore. They get pregnant on their own. So reproductive wellness, we want the patient to be in the best shape possible, not only so that she could get pregnant, but she could have a healthy baby and a healthy pregnancy. So reproductive wellness is something, smoking, drinking, marijuana, etc. So, you know, we really dwell on all of that because that impacts everything: egg quality, sperm quality, and the ability to conceive. So we are very focused on that.
Thank you so much. Dr. Kumar?
In our practice, what I try to insist on is that we encompass diet-wise. I think quite often we try to distill goodness down into a pill. We want to be able to take our coenzyme Q10 or something else and then hope and pray that it fixes the rest of our diet. But quite often, I don't believe it's that easy. So I do focus on a good, broad, healthy diet with plenty of diverse fruits and vegetables. And then we talk about physical health in terms of getting at least 15 minutes of exercise 4 or 5 times a week. We talk about mental well-being. It's been well documented that the stress of going through fertility treatment is the same level of stress as going through cancer treatment. So I myself am a big proponent of mindful meditation. I've used it myself. I think it works really well. So I think it's not just wellness in one area, but wellness across all of those areas, and changing our lifestyles in general to better promote fertility health.
Thank you so much. Thanks. John, we have a question in regards to acupuncture from one patient. Can you take that question for us?
Yes, sir. Yeah, so Mr. Berkley, I guess there's a patient who had a question at 42 years old with an AMH of 0.6, successful prior non-IVF live birth. She was wondering, how can we improve egg quality? Specifically, does acupuncture help? So I'll pass that along to you.
So it's a great question. It's a great question. I'm always going to try to stay positive. I'm not too positive in this kind of case for a couple of reasons. I think this is an advanced maternal age case with an obvious, very low ovarian reserve. And what's usually concomitant with low ovarian reserve is poor egg quality. Now, having said that, acupuncture is a trophic form of intervention, meaning that we can actually drive blood to where we want to drive it. If somebody has elbow pain and you put needles in the elbow, all this blood and nutrient products will go to the elbow. So through utilizing certain acupuncture points, we can improve hemodynamics to the ovaries and the follicles. And the purpose of that is to increase the delivery of oxygen, hormones, electrolytes, nutrient products, and to increase the excretion of debris. And hopefully, well, let me restate, many times, though not always, that type of intervention can improve egg quality. And so sometimes what I say to patients to encourage them, but I say it with all honesty, is look, you may have low ovarian reserve, But in order to get pregnant, you only need 3 or 4 things. You need 1 good egg and 1 good sperm and a good endometrium and an absence of mitigating disease. So it's worth trying if the patient wants to give it a shot. So that's, I think, the best answer I can proffer.
Thank you so much. Dr. Bustillo, how do you treat patients who have low quality eggs?
Well, that's a very good question. And I think you have to try to figure out, why do they have low quality eggs? Is it because they're old, you know, or what? Are they PCO? And you might want to try to improve it either with metformin or inositol, or what other kinds of supplements that you might improve their ovarian blood supply, acupuncture, etc. It's very difficult. And sometimes what you can also try is different kinds of stimulation, because I've seen patients with one kind of stimulation have horrible eggs, and maybe we try a little bit different stimulation, lower doses, maybe a combination with letrozole, whatever. So what I tell the patient is, if they're over 42, 43 and really low AMH, they're going to have poor eggs, and they're probably not going to have very many eggs. So yes, you can try some things, but it's going to be difficult. But our younger patients with poor eggs, and we have those, a lot of it is trial and error with trying to think about, how can I possibly improve it? Could I improve it by lowering your total body inflammatory markers, which our nutritionist is really into that. And she has some great data that we haven't even put together or published yet, that when we improve that, we actually improve egg quality. So how exactly, it's kind of hard to tell, but there are certain strategies that you can try to improve egg quality.
Thank you so much. Dr. Kumar?
So in my practice, and unfortunately or fortunately, we deal a lot with older patients with lower ovarian reserve. We tend to use quite a lot of human growth hormone. In those settings, we tend to use testosterone priming. But I think quite often the key is a lower dose stimulation, a gentler stimulation, and repeat attempts. In my personal experience, which is obviously not the way we want to practice medicine, but the way I've come to understand ovarian physiology, there are going to be some good, healthy eggs in there. Sometimes it's not the protocol, it's not the pre-treatment, it's not this or that. It's just staying in the game long enough to have a healthy egg. I think that's what I found, is that we had this one couple where she was a well-published author. Her husband was a scientist, and so we embarked on I think 7 or 8 IVF cycles, and we tried everything, all kinds of Eastern medicine, all kinds of Western medicine, and it was very humbling in that there wasn't a great deal of correlation, and the success that we had just came from random things rather than from any organized effort. And I think that has been humbling, and quite often, I think the success that we have is being transparent about that, saying that success will come from repeat attempts and not just from finding some perfect strategy.
Very good. We have another question that is very related to stimulation protocol and how that impacts equality. John, if you can help us get that question from Terry.
Yes, sir. Let's see. Let me get down here. So she had a couple questions on stimulation's impact on egg quality. The first one was, how does elevated progesterone levels at the time of the trigger affect egg quality? Do you want me to ask all 4 or all 3 and then go from there, or do you want an individual?
Let's start with the first question, and the first question first. We'll start with Dr. Bustillo and Kumar. For Mike, I have another question for you after these 3 questions, which is also related to the same thing.
Certainly.
I'll start. We published a paper a long time ago, before, in the 80s, about progesterone levels at the day of HCG trigger. And I think the biggest problem with that is that what it really affects more than anything is probably the endometrial lining and the development of that. It's probably not so related to the egg quality. And I think it has, and what we saw then back in the mid 80s, one of my fellows did this, We published it because what we were seeing high progesterones up to you know, et cetera, with young patients who had a lot of follicles, you know, and a high estrogen level and a high progesterone level, and that did not affect their egg quality. So progesterone, it's a question. I wouldn't certainly not cancel a patient because of a high progesterone. Might consider not doing a fresh, most people aren't doing fresh transfers anyway, but I would not necessarily. And if they have such high E2s anyway, they're going to probably be triggered with Lupron, in which case you're going to freeze all their resulting blastocysts anyway. So I'm not that concerned. We do measure progesterone, and as it starts to creep up, then if we're questioning whether we're going to trigger that day or the next day, we might trigger them a little sooner than later. But we're not that concerned about egg quality and progesterone levels, not in my experience.
I find the same to be true. We can even stimulate ovaries in the luteal phase when the progesterone level is high and get favorable embryos for transfer. We have donors that still have a Mirena or progesterone secreting IUD in. We get eggs and the embryo quality is excellent. So I agree that it affects more the endometrium and not the egg quality.
And how about FSH versus FSH-LH combination? Does it have any impacts?
The combination of the medication we use for ovarian stimulation?
Yeah,
Yes.
FSH versus FSH-LH.
Of course, I think LH is going to drive the theca cells to convert cholesterol to testosterone and finally to progesterone. And FSH takes that testosterone, so cholesterol, progesterone to testosterone, and FSH converts testosterone to estradiol. So you find stimulations that are only FSH dominant, and then you have very low estradiol levels, takes longer to develop, and it's a little bit of a dysfunctional stimulation. So I think it is important to get the right ratios.
Dr. Bustillo, the same, do you agree?
Yeah, I mean, the major question, I used FSH and LH on most of my stimulations. So the question is how much? So what kind of ratio? I tend to use, for instance, a combination of GONAL-F or whatever, FSH, recombinant, and, you know, Menopur, whatever, which has FSH and LH. And I tend to have a lower LH concentration, and they seem to do okay. But I think patients do, in general, a little bit better if you have at least some LH on board.
Some LH.
Same reasons that you mentioned.
And as far as duration of stimulation, 10 days seems to be the predominance. How about below 10, 9 or 12? Does it apply? Would you consider using longer or shorter?
In general, I don't like to trigger before day 9. I will trigger on day 9 sometimes, but most of my patients are triggered on day 10 or 11. In general, they seem to do better. We've looked at this. It probably doesn't make a huge difference, 10, 11 or whatever, but we go by follicle size, estrogen levels, you know, that kind of thing.
I would say 90% of my triggers are day 9 and day 10, rarely day 11. But there are some stimulations that go 12 or 13 days, and I'm okay with it. Sometimes the ovaries are more suppressed by the oral contraceptives preceding the cycle. What scares me a little bit is the early trigger. I'm very reticent to trigger on day 8. I think we'll get a lot of immature eggs, sometimes even regardless of the size of the follicles. The only time I do a day 8 trigger is when I see my day 3 estradiol is already high, and I think they may have started developing the follicles on their own before I started the medication.
Very good, very good. And the size of the follicle, does it matter? Does it have to be between certain size, 18, 20, or is it something that varies from case to case?
For me, I can tell you that there are 3 criteria I look at: the duration of the stimulation, the rise or the delta in the estradiol level from the 2 days previous, and then the size of the follicles. And I think you cannot use any one criterion on its own. You have to build a mental image of what's going on in the ovary and then try to make the best judgment. Very
good. Dr. Bustillo?
No, I pretty much agree with that. We don't like to trigger before they're at least more or less 20 millimeters. I like at least 2 greater than 18, and then the majority of the other follicles over 16, 17. Okay, sometimes you have some follicles that go ahead of the others, and if you're already on day 10 of stim and your estradiol is good, then we go ahead with that. So in general, 18 to 20 is when we feel comfortable triggering.
Very good. Thank you so much. Mike, we had a participant on the chat that was asking about literature that demonstrates the effect of acupuncture on egg quality.
So that's a great question, and I'm pleased to respond by saying that there is abundant literature coming out of multiple studies that attest to the efficacy of acupuncture in the context of enhancing fertility outcomes. And the way to find this literature is simply to go on Google and type in scholarly articles, acupuncture infertility. If you don't type in scholarly articles, you'll get articles written by me and you know, just acupuncturists who are obviously, you know, everybody's self-serving to some extent, but there are multitudinous studies available these days.
Very good, very good. Thank you so much. John, can you take another question from another patient?
Yes, sir.
Maybe,
Yeah, so which one do you think, Dr. Arash?
maybe we can take the one that was going to be asked live, which is the first one that you have.
The spontaneous pregnancy?
Sure.
Okay. So this one's from a patient. She had a spontaneous pregnancy that resulted, well, actually, no, this one was already read. So let's do this one. There's a 55-year-old male patient that has a low sperm count and motility issues. Partner is 45 years of age. Patient has had 2 successful pregnancies with ICSI in the past. Are there any natural remedies for male factor infertility?
Is that addressed to me?
To all.
Okay.
Whoever wants to answer.
I think with a 45-year-old partner, there are other issues at hand.
That to me is a bigger issue,
Yes.
because the other can be overcome with ICSI, but if you've got a 45-year-old female, then you got issues big time. So
Yes,
yeah,
so
you know,
If
I think, again, my approach to the male is get rid of anything and everything that might be negatively influencing you, like marijuana, too much alcohol, heat, etc., and lifestyle issues like we talked about before, and try to improve it that way. There is some evidence that some antioxidants and vitamins might improve your morphology, etc. And then make sure you don't have anything else, you know, varicocele, whatever, obstruction, whatever, by a good reproductive urology assessment. But if you got a 45-year-old female partner, we've got major issues there.
So I think I took a little bit of a slightly different approach, a different perspective, though I completely agree with what you're saying. I think that generally men over 40 certainly have poorer sperm parameters than younger men. And so even if you have a couple where the man is 50 and the woman is 45, let's just say that this ends up being a donor egg case. Still, I would like to do acupuncture and perhaps herbal medicine on the man to improve sperm parameters, so that then if they do donor egg, at least we'll have one part of the equation that will be utilizable.
I agree with that. I think I'm always of the opinion that you should try to optimize the sperm no matter what.
So if we put on aside the age of the partner and the difficulty that come with that, what would be your treatments for this patient?
Well, I think you need to make sure that you understand what might be possibly causing the problem. So a good diagnostics, you know, if he's got a low count, et cetera, you need to check him hormonally. Does he have, you know, an elevated FSH? I just the other day diagnosed for the second time in my career a prolactinoma in a man. All right, because his sperm count wasn't the greatest. And I said, you know, he deserves a little bit of a workup. I'm a gynecologist, but I got hormones on him and his prolactin was 200. And he has a 2-millimeter pituitary tumor. And so, you know, we need to treat that and hopefully it'll improve its count and hopefully they'll be able to get pregnant. So I think if you have to kind of figure out what might be the reasons why people have bad gametes. And if you figure out the reasons, then you might think about the potential ways that you can improve them. Because it's better to being a good egg and a good sperm together overall.
Thank you so much. Dr. Kumar?
In regards to male factor, I think that I agree with lifestyle changes. I agree with getting a workup, including thyroid, prolactin, a karyotype. I usually am not a big advocate for Y chromosome microdeletions.
Right.
Because quite often, well, there's nothing to fix in that case. With if there is a karyotype issue found, obviously, then we can have something to look for in the embryos as well. So I completely believe in doing that. I think that, again, what I recommend is lifestyle changes. I'm hesitant to say that, you know, any one thing will fix it, but it's not that we need to go on a specific diet or anything like that, but we need to alter our lifestyle. So in general, that we're better. And I think included in that is our mental health as well, because, you know, we quite often talk about the pressure that the female partner's in, but, you know, I think a lot of that is shared by the male partner as well, especially when there's male factor involved.
Very
I agree.
good. Thank you. We have a question live from Juliana. Juliana, are you there?
Yes, I am.
How are you doing?
Doing well, thank you.
Very good. Please ask your question.
Yeah, so recently I had a failed IVF treatment. We transferred a normal PGS tested embryo and everything was good. My thickness was perfect. Everything was great, but it ended up on a blighted ovum. And then today, we actually talked with a doctor, and she think that I might be having a silent endometriosis. And one of the things that she discussed is potentially remove the tubes, since it will not be useful in IVF anyway. So in my case, how would you treat a patient with endometriosis successfully without removing the fallopian tubes?
Can I jump in real quick on this?
Sure.
So, Juliana, first of all, I want to ask you, how is it that your doctor knows that you have tubal adhesions? And how is it that your doctor knows that, in fact, you have endometriosis?
Well, I have a blocked fallopian tubes from, I had an HSG. So that's how the diagnosis.
So, so were the tubes blocked or were they scarred? Did they have adhesions on them or were they just blocked?
No, the question is whether you have a hydrosalpinx.
Unfortunately, I don't know that
Well, the
yet.
hydrosalpinx would be a good thing to remove.
Right.
Or at least block the tube so that liquid doesn't get into the, we, again, looked at this years ago, and we know that hydrosalpinx fluid is bad for embryos. Bad for embryos, bad for implantation, bad for success rate. So if you have bad tubes that are blocked distally on the ends and you have hydrosalpinx, we would probably remove that before we put an embryo. Yes, there you go. So tubes like that, okay, that are blocked on the end should be taken care of before we do IVF in general. Now, if you're older, you're going to do PGTA and you don't know what the results are, you could do that. But before you have a transfer, it would be a good idea to take care of the tubes.
I'm just a little concerned about the diagnosis for endometriosis because I'm not really hearing that there was an adequate diagnosis done.
Well, it may not be needed because endometriosis is usually what happens on the outside of the uterus, on the ovary or on the tube, and it should not affect the implantation rate. If there's adenomyosis, and that's endometriosis of the muscle of the uterus, that may affect implantation, and that you won't be able to diagnose or treat with a salpingectomy. So I think I agree with what Dr. Bustillo said, is if you have a hydrosalpinx, which is a dilated tube, get it removed. If the tubes are blocked already, removing them, and they're not dilated, removing them will be completely ineffective. They're already blocked. So then in that case, you may want to look for adenomyosis.
Dr. Kumar, may I ask Dr. Kumar a question?
Yes, sir.
So it's my understanding, respectfully, that endometriosis contributes to infertility not simply because there's tubal damage, but because these pro-inflammatory cytokines find their way into the uterine cavity, causing an inflammatory state, a Th1 predominant state to begin with. And secondarily, there's no pinopoid elevation, which changes the ability of the endometrium to facilitate an implantation. So I'm not sure that endometriosis is just mitigating of fertility simply because of tubal adhesions.
Well, I think that's all controversial, and I think we were talking about this before we started the seminar or the webinar. If sometimes patients like this have elevated natural killer cells and other reasons why they either miscarry or don't implant. The other question I have, you had a blighted ovum with a PGT normal embryo. Did you have a DNC, and was the tissue re-examined? Because the question is whether there was an error in the PGTA. I know you guys never make errors, but you want to confirm that. And then you have to figure out, why did you miscarry? Are there other reasons, you know? The fetus didn't develop, but you know, was it because it isn't getting appropriate blood supply? Do you have antiphospholipid antibodies? Do you have other kind of coagulopathies? And we'd work you up as a miscarriage patient, even if, you know, hopefully not based on the PGTA result being abnormal.
And Dr. Kumar, you were asked a question. Do you want to comment on that question?
I think Dr. Berkley, that endometriosis would affect, or Ms. Berkley, it would affect fertility in 3 ways, in my estimation. One, it would be the pelvic scarring that would make it difficult for the egg to be retrieved by the fimbria. Second is we definitely see a decline in egg quality because of the inflammatory state induced by the endometriosis. My personal perception is that we're not going to have endometriosis associated increase in inflammation just, you know, diffuse into the endometrium. I think that seems a little implausible. My personal feeling is that in these individuals that have this severe endometriosis, they actually have what is now ICD-10 called endometriosis of the uterus. So there is undiagnosed adenomyosis being endometriosis of the uterus, and that is what is leading to the poor implantation. So I agree with you, but I think it's specific to the muscle of the uterus, and that if you have endometriosis, let's say anywhere else in the body, in the lungs, in the pelvis, etc., it's not going to lead to the poor endometrium.
But again, this is very controversial. And again, reproductive immunologists like Dr. Coulomb, who's very well known, she always tells me about 50% of patients with endometriosis have abnormalities in some of these things like NK cell, et cetera. So there's an association. Some people believe that endometriosis is an immunologic disease. Back when you used to do laparoscopy and see endometrium inside when the patient was menstruating in 60+% of women, and they didn't have endometriosis. So why is it some women develop it and some of them don't? It may be that some sort of, and that's been shown, that macrophages are insufficient for cleanup or whatever. So there may be an association on this interaction between woman, endometrium, and embryo that might be abnormal in patients with endometriosis. So my approach to failure for after this, and if I have one embryo only to transfer in the patient, I generally try to test them for some of these things. But again, I know it's controversial, but I've had a lot of experience and very good success rates with that.
I'm not sure that being controversial should be construed as a negative thing. I think
I agree, but a lot of people call you bad names when you do things that are
right. Well, as long as you're producing babies, they can call you all the names they want.
I don't care.
Right.
Let's Jillian, are you still there?
Yes, I am.
Do you have any other question?
Yes, and I'm taking notes. Thank you very much for all the insights on that. I appreciate that.
You're welcome. Would you like to ask one more question?
Oh, well, I'm very interested about what Dr. Mentioned about hydrosulfings.
Yeah.
And how do you test Or how will I know that I have the hydrosalpinx?
Oh, well, if you had a hysterosalpingogram, it shows up. So your tubes fill, and at the end, they're like big sausage balloons. So they don't go, the fluid doesn't go into your pelvis. And that by definition means you have water, which is hydro, in your salpinx, hydrosalpinx in your tube. So it's a diagnosis either because you can see it on ultrasound sometimes, or because you've had a hysterosalpingogram.
Okay.
So if you had a hysterosalpingogram, they should be able to tell you you have or don't have a hydrosalpinx.
Okay, thank you.
You're welcome.
Thank you. Thank you, Juliana, for your
Good luck,
questions.
Juliana.
Thank you.
And good luck to you. We have another question from a patient's a live question. Riley, can you take that question for us?
We have an anonymous patient. Hi there, can you hear us?
Hi there, yes, can you hear me?
Yes.
Hello.
Wonderful, thank you so much for all of this. It really resonated with me about fertility treatment being like going through cancer treatment, because it definitely feels like that. So thank you for acknowledging that. So anyway, I guess I'm just calling in because I want some hope, and I'm sure I represent others on this call. So 42 years old, naturally conceived a healthy baby boy 2 days before my 40th birthday, want another one, have had 2 miscarriages from spontaneous around week 7. Genetic testing did not work out because I guess it was a female embryo, and so it was whatever. The test didn't work out as to what happened with those 2. And then 3 failed IVF cycles. So I always get eggs, but they're rarely normal. I had 1 euploid the first time around, which failed to implant. So I'm at this point now where I read articles where they say, you know, at my age, and my AMH is 0.6, by the way, otherwise perfectly healthy, regular cycle, I ovulate, all that. I feel like I get pregnant, I can't stay pregnant, probably egg quality issues. Is there hope? B, do I keep doing IVF? Or C, do I just let myself naturally conceive and it's a numbers game and it'll eventually happen? Quick anecdote, my grandmother had her 13th baby at age 46 in the 1950s. So I hold out that maybe it runs in the family, but looking for some advice.
Thank you so much. Dr. Kumar?
No, I do hold out hope for you. I think that hope is not lost, and I apologize that you're going through such difficulty. My feeling is that the answer to your question is that perseverance will pay off. I would maybe suggest a minimal stimulation, which is perhaps more cost effective, less stressful to you, and given a few more tries, I'm confident you'll be able to do this.
Very good. So as far as conceiving naturally or trying more IVF, what would be your recommendation?
I have a biased worldview, so I apologize. I would recommend IVF. I think that the fecundity rate for spontaneous conception, or meaning the chance of you conceiving on your own, is low, and my desire would be to try to get that as high as possible, given that the opportunity cost of time going by, the egg count getting lower, the egg quality getting lower, is too high to just wait.
Thank you so much.
May I just ask one question of the patient?
Of course.
How many IVFs or how many transfers have you had?
It was 3 stimulation cycles and then 1 transfer, because I only had 1 healthy embryo of those 3 cycles.
So that in and of itself is an indication that you should certainly try to do more IVFs because you've only had 1 transfer.
Thank you so much. Dr. Bustillo, what's your response?
No, I agree, and I agree with Dr. Kumar that maybe slight lower stimulation might be better, and you should try to produce more embryos. But then the other issue is before you transfer a normal PGTA embryo and you've already failed once, if the embryo is really good quality, what we're seeing is if the trophoblast isn't so great, then our pregnancy rates are terrible. But if you've got a really nice embryo, then you might want to think about looking at some of these controversial immunologic testing before you have the embryo transferred, if you only have 1 embryo, just to maximize in case you might want to need intralipid or something like that. So, but, I mean, the question is whether anything that we do is going to be better than you trying on your own. That's the question I have to sometimes tell my patients, that I don't know if I'm doing anything for you. But if I can, in a woman your age, if I can achieve a normal, genetically normal embryo, that's got to be better than the pregnancy rate per cycle in a patient your age who isn't being tested. So if you can stand it for a few more tries, but the question is, when do you say no? And how amenable are you to egg donation to complete your family? Because certainly the success rate of that generally would be much better.
Mm-hmm.
Yeah.
Okay, thank you.
And just to put this in context, the patient had a baby at 40. So
I understand. And she's got great genes from her grandmother, but she's got a low AMH and she's older now. So, I mean, yeah, I mean, you just have to decide how much more you're going to do of that. And I certainly wouldn't do it without testing the embryos.
Okay.
Thank you. Thank you very much.
The likelihood of having an abnormal embryo, based on our data, based on more than 40,000 embryos at the age of 42 or more, it's approximately 15 to 20% at best. So that's the likelihood of having a normal embryo, with karyotypically normal, right? And that what that means is you really have to have the numbers to be able to get that statistics. If you are 42 and you have 5 or 6 embryos, there is a chance you can have one there.
Right. The problem is if she takes 4 stimulations or 5 to make that number of embryos, that's the issue. Yes. So that you need to, you know, your psychological, how much you can put up with and all of that needs to be factored in, your mental state, your wallet, you know, and decide. And if, again, I love egg donation, you know, I was involved in it from the beginning, and I think it's a fantastic technology. I understand everybody wants to have their own genetics passed on. You already have a genetic child, and one of the ways you could also adopt a baby or whatever. So there are other options, but yes, you can continue. But the question is how long and how often, if you're making, you know, 1 embryo normal out of 4 cycles or whatever. So yes, I mean, that's what I tell my patients. The chance of you having a normal embryo is probably not more than 15 to 20%. And if you only make 1 embryo to biopsy at a time, then we're going to require a whole lot more cycles. And then you need to decide, put on yourself, you know, what you might want to do, you know?
Yeah, thank you so much. Mike, do you have situation like this where you have patients that are trying to conceive and they need help?
Yeah, I mean, this is not an infrequent complaint. It's not an infrequent type of patient. And, you know, I basically agree with what all of you have been saying. I would try to encourage this patient to do, you know, mini IVFs with low doses of gonadotropins, because certainly high doses are not going to present any more eggs than low doses in her case. And of course, using acupuncture on this patient to try to improve hemodynamics to the ovaries may be the tipping point and may not. I'm very humble about what I do. I don't think that acupuncture is necessarily the answer. I think it may be part of the answer. And so I would recommend to this very lovely young lady that you would, if you have the mindset and the financial wherewithal, to try to do a few more cycles and to include acupuncture as part of your protocol, because that is something new that you're not currently doing that may make a difference.
Fantastic. Thank you so much. We have another question that was asked, that she was supposed to be live, but she ended up not attending. John, do you have the list of questions from live questions that you could take one?
Yeah, let's see.
There is one from a PGTA accuracy and rebiopsy, number 3.
Yeah, yes, sir. Yes, sir. All right. So this is from a patient. She says, I had my egg retrieval in March due to COVID. Things were put on hold. Early June, I had a damaged left tube from ectopic pregnancy removed due to a recommendation from my IVF clinic. I went in July, had a cyst on my left ovary and went back in August, had another cyst on the right ovary. They had me start a generic version of Provera, start my cycle, and to hopefully shed the cysts. I'm currently waiting for my cycle to start to see if the cysts have diminished or disappeared. How long should I wait to do my transfer after being on Provera and after the cysts are gone? And then she goes on to ask how accurate are PGS tests. So that's the question. So I'll give that to Dr. Bustillo.
Well, I don't think she should. Once she has a menses, she can start her cycle at any point. Just because she's been on Provera doesn't mean she's not, because she's gonna, I gather what she's doing is a frozen embryo transfer cycle that's already PGTS or S normal. I don't know, but that's what I'm assuming. The question is, if she's had a cycle and the embryos were frozen and she's trying to do a frozen embryo transfer cycle,
Correct.
then I would do it at any point. I'm not usually bothered too much by ovarian cysts. If they're functional and not producing any estrogen, she could be on Provera, and even if it's still there and has low estrogen levels, you can start the stimulation. All you really care about at that point is the endometrium and that it develops that, you know, appropriately, and you could proceed with that.
Thank you so much. Dr. Kumar?
No, I agree. I think that the key to starting a frozen embryo transfer cycle is having low estradiol and progesterone so that you start growing the lining for the transfer itself. And if it's present or not, as long as it doesn't interfere with those levels, then we can disregard it.
Right.
And the risk of rebiopsy, because that was one of the questions she asked, what is your opinion about rebiopsy in an embryo? Does it impact the, the embryo in any way?
Sure. So we actually have a good amount of experience with this. Rebiopsying the embryo does impact the viability. Every time you stress the embryo, you're going to lower the chance of success somewhat. We used to get embryos shipped from a clinic overseas at the blastocyst stage. And so for every patient, we would thaw the blastocyst, allow it to re-expand, biopsy, refreeze, get the PGTA results back, and then do the embryo transfer. And we actually saw success rates that were about 15% lower, 20% lower than our typical success rates. Now we have them shipped over on day 3. We throw them to blastocyst biopsy and then refreeze, and our success rates are better. But I think that unfortunately it does affect the viability. A lot of it is quality in is quality out. If you have a beautiful AA blastocyst, it's going to do well. If you have a BB blastocyst, it's going to do okay. If anything below that, it's not going to do well at all. So a lot of it depends on the embryo itself.
Thank you so much. Dr. Bustillo, rebiopsying an embryo.
I want to make sure I understand what you mean by rebiopsying. You mean one that's already been biopsied once?
Yes.
So you're biopsied, frozen, and rebiopsying?
Yes.
All right, the question is, why would you have to rebiopsy? The only reason would be because there was no DNA and you want to,
yeah.
We've done that and we've had pretty good success rate, but I think I agree completely with Dr. Kumar, and it has to do with the quality of the embryo. There are embryos that are frozen, and my embryologist will tell me, and I have patients now coming back for baby number 2, and they've had a boy, and now they've got 6 embryos, and they'd like to have a girl, and so could we thaw them, biopsy them for gender selection, you know? And I have to have them look at the embryos and with me agree whether this embryo we think will survive the thaw biopsy. And these are ones that haven't even been biopsied yet. We have lots of data and we have good results, but not every embryo. An AC embryo is not the same as an AA embryo, and a BC embryo is differently worse than that. So I think I say, yes, some embryos can be biopsied after being frozen or rebiopsied. If they have no DNA on the first biopsy and the patient only has that embryo, everything else is abnormal, then I'm okay with that. But I think a lot of it has to do with the quality of the embryo, whether it can withstand, as you say, the thaw, the biopsy, and the refreeze, because that's what we have to do. So, when the patients come back because they've had a baby of a certain gender and want another one, and unfortunately they didn't do the PGTA to begin with because it wasn't indicated because they were young, then that's a different, you risk not being able to biopsy your remaining embryos later on. And it doesn't mean that you won't have a baby with the ones you have frozen, but it may be that if you biopsy it, it may damage it enough that you wouldn't have a baby. So it's an interesting discussion, but I think you have to see what you have before you make that decision.
Do you guys have any stats on rebiopsy and implantation rates, pregnancy
No,
rates?
we were just discussing this at our little research meeting the other day, and we decided, I was just pulled out all the articles that have been published, and we need to look at our data. We haven't got a database specifically for that, but we have now probably at least a couple of hundred embryos that have been re-biopsied or biopsied post-freezing the first time and thawed and then refrozen, and we have pretty good success rates. So we need to correlate that though with embryo quality, I think.
Very good. Dr. Kumar, any comments on statistics, if there is any data there looking at rebiopsy outcome?
So these are the data that the implantation we had with our day 5 biopsies and refreezing was, I think, 59% implantation. And usually it's about 15-20% higher. So it's quite a bit lower.
Slightly lower, 15% lower?
15-20%.
Yeah, and that's probably because some of the embryos are not that great than others. Maybe there are some
I think it's just stress induced, and then there's only so much stress that the embryo can handle.
Very good. Excellent. Thank you so much. We are coming close to the end of the webinar. I would like to give each one of you a chance to introduce your practice and tell us what you do for patients. And I will start with you, Mike.
Thank you so much. So this has been wonderful. I appreciate all the brilliance that you guys have exhibited, and I've loved participating. Thank you. So I'm Mike Berkley. I'm the founder and director of the Berkley Center for Reproductive Wellness in New York City. I'm a licensed and board certified acupuncturist. I'm a board certified herbalist. My practice is completely devoted to treating infertility cases and has been for 23 years. Is it okay if I announce my website?
Of course, of course.
Thank you. My website is berkleycenter.com. And of course, Berkley is spelled Berkley, berkleycenter.com. Thank you all very much.
Thank you. And Dr. Bustillo?
I'm based in Miami, Florida. I'm a reproductive endocrinologist. I've been doing this for 39 years. I work at IVF MD. I have been in and out of academic medicine, so I'm always looking for answers to everything and asking lots of hard questions. I was involved in the very first egg donation in the United States in 1983 with a different technology that we used back then. So I have a lot of experience with a lot of different kinds of infertility. I have done pretty much it all. But because I've been doing this for so long, I get a lot of patients who are difficult, meaning I'm sort of the expert on implantation failure in the community. So I get the patients who've had 3 and 4 and IVF, transfers or whatever, and I try to figure out what we can do to improve things and get them pregnant. And it's very satisfying what I do.
Thank you so much. Dr. Kumar?
Hi, my name is Ashim Kumar. I am the director here at Western Fertility. We're in Los Angeles. We actually started off about 4.5 years ago, 5 years ago, and our focus was a lot of third-party reproduction, egg donation, surrogacy, and a lot of both. Originally, about, I would say 60-70% of our patients came from outside of the area. Many international patients from Europe, from Asia, from China, Australia, etc. Obviously, now with the COVID crisis, most of our patients are local or national. We do have patients from all over. And quite a lot of it is, like Dr. Bustillo says, it is patients that have failed treatment elsewhere. And our focus is on returning to the science. And I am very, I would like my treatment to be focused more on the science rather than on conjecture. But I think that if we stick to the science and are honest and transparent about the possibilities and prepare for that rather than just bounce around from idea to idea, then we can have a good outcome.
Thank you so much. Well, with this, we are coming to the end of the webinar. I would like to thank each one of you for your contribution and for your support to patients and your dedication. Next week, Thursday at 3 p.m., we will have another webinar. This time is going to be a scientific discussion on the potential role of progesterone as a trigger, a new concept that has been on and off. I will let the details later on. Thank you so much for attending the webinar, and I will see you next week. Thank you so much.
Thank you.
Thank you.
Bye, everybody. Nice meeting you guys.
Nice meeting everybody. Have a lovely evening.
Bye, Mike. I'll come see you in Manhattan.
I would love it if you would. So nice to have spoken with you. Take care, everybody. Thank you again.
Thank you.